Good day, everyone. Welcome to the 7th webinar in the Suicide Prevention webinar series. My name is Meg Schellenberg, and I'm a knowledge broker here at the Mental Health Commission of Canada. I will be your host for today's webinar, which is being delivered at a special time and date in recognition of World Suicide Prevention Day. Before we begin, it would be great if everybody could introduce themselves by using the chat function, which can be found on the right of your screen. As shown on the slide in front of you, you should see a small chat box with a drop-down menu. This is where you can ask questions or make comments either during or after the presentation. When asking a question, please send them to all participants rather than all attendees or all panelists. This is so everyone participating can see the questions and conversations as they happen. I also want to mention that this webinar has been pre-recorded, but the Q&A following the presentation will be live. A French version of the slides will also be available in the coming week or two. Due to the large number of participants on today's call, your phone or computer is on mute. If you wish to ask a question privately to me, the host, please send it to the host, which can be found in the drop-down menu of the chat function. For those of you who are unfamiliar with the Commission's mandate, we were formed in 2007 with a 10-year mandate, which is visible on your screen. We are catalysts for system and social change that leads to improved mental health for Canadians. We also work closely with the people and organizations that have a role in transforming the mental health system. Now that we're in the second half of our mandate, we are shifting from knowledge generation to a stronger focus on facilitating and creating change. Currently, our work is focused on 5 priority areas, suicide prevention being one of them. All of our work is informed by the Mental Health Strategy of Canada, which was released in 2012. The Commission is committed to the prevention of suicide in Canada and has made work in this area a top priority. The purpose of this webinar series is to share knowledge and highlight promising practices about suicide prevention, postvention, and intervention, both within Canada and internationally. By doing so, we hope to create a platform in which people can speak openly and honestly about suicide and come away with a better understanding of the issue. We also encourage dialogue from participants and offer ways to connect with our experts to explore each topic further. As I mentioned previously, today is World Suicide Prevention Day. Today, people will gather in communities all across Canada and around the world to show their support for suicide prevention, to remember and celebrate the lives of those who have died, comfort those who grieve, and strengthen our connection with one another. During World Suicide Prevention Day, we remember that we are all connected to each other through shared experiences, sorrow, hope, determination, commitment, and compassion. If you want to know what's happening in your community today, you can click on the link that is found in the chatter box or on the screen in front of you, where there's lists of events happening around the country. One really exciting opportunity that I would like to briefly mention is an upcoming virtual conference focused on suicide prevention, postvention, and intervention. Building on the theme of Connecting Canada, the Commission has partnered with the Canadian Association for Suicide Prevention to deliver an online conference this upcoming November. This conference will take place entirely online and will feature keynotes from leading experts in the field, as well as engaging and very informative concurrent sessions. To learn more about the conference or to register, you can click on the link on your screen or the link that's found in the chatter function. So without further ado, I would like to welcome Liz Fisk, who is leading the presentation today. So Liz, over to you.
Thank you very much, Meg. It's a pleasure to join you and everyone on this webinar series. Today, we're going to be telling participants about the Canadian Distress Line Network from both a historical and a needs perspective. Our focus will be on community development, some of the strengths and gaps in the service system at now, and at the end, there's going to be a call to action as well. Next. Thank you, Megan. We always find it's fun when you're on a webinar to get a bit of a mental image of the speakers. So for everyone's benefit, we're giving you a quick peek at who your presenters are today. Myself, Karen Latofsky, and Janet Smith. Thank you. Next slide. So let's set the background here. In recent years, mental health has become a growing concern across Canada. According to the Canadian Community Health Survey on Mental Health from 2012, 10% of Canadians reported symptoms consistent with mental health or substance abuse in the past 12 months. Of those who expressed concern around their psychological well-being, were experiencing a mood disorder, a quarter said that they deal with anxiety, and nearly just under half mentioned issues around substance abuse. Today being World Suicide Prevention Day, we really need to focus on suicide in Canada. Today, according to CASP, the Canadian Association for Suicide Prevention, approximately 11 people will end their lives by suicide. In addition, approximately 210 other individuals will attempt to end their lives in this way. For each suicide death, it has been estimated that the lives of 7 to 10 bereaved survivors will also be affected. That means that today in Canada, 77 to roughly 110 individuals will become newly bereaved by suicide. This certainly leads us to the understanding that suicide is a critical public health issue in Canada. One of the other important things that we're going to be talking to you about today is social support. Connections help keep people safe. Social support means having people to turn to in times of need or crisis, to give you a broader focus and a positive self-image. Social support enhances the quality of life and provides a buffer against adverse life events. Research shows that not only can perceived social support have a direct benefit on health and mood, but utilizing social support in which people seek out their networks has been shown to have an even more positive effect. By assessing the supports that are available, individuals are able to receive feedback and resources for problem solving. Both perceived and utilized social support has been found to protect people from depression and suicide risk through ensuring contact in time of crisis and increases in self-esteem. Next slide, please. Continuing on with the theme of connections help, let's talk a little bit about distress centers and lines. Here in Canada, there is a proud history of over 40+ years of psychosocial support. Predominantly, these services have been telephone-based, certainly for the majority of the last 40 years, but currently they are expanding to include online chat and text-based services. Most of the distress or crisis centers or lines across Canada started as grassroots organizations using volunteers. Many of them were based on the Befriender model that was popularized by Chad Barra and the Samaritans in the UK. The important thing for us to remember today that these lines were started in the days when suicide was still a crime. Distress and crisis lines across the country provide a wide range of support, emotional support, crisis intervention, and suicide prevention, intervention for suicides in progress, and also postvention services. It's also important for us to realize that the ability to access these services varies across the country. It's going to be a theme we'll explore several times today. Meg, next slide, please. The Canadian Distress Line Network is a very important enterprise that those of us on the presentation today are very happy to be a part of. It was an initiative that was started back in 2002, and its focus has been to bring together those centers who believe in the model of befriending, intervention, and suicide prevention. What the Canadian Distress Line Network is doing is engaging these organizations and focusing on building a national network that has a formal structure. The Canadian Distress Line Network has received an additional impetus within the last year and a bit through the support of an anonymous funder, which we wish to acknowledge and thank, and it continues to be a work in progress. Our mission is to be dedicated to enhancing the personal resiliency for individuals who are emotionally vulnerable or in crisis. Next slide, please. What's this initiative going to do? Well, it's going to connect Canada. It's going to do this through a number of different manners. Those will include knowledge transfer, pan-national best practices, and the establishment of a national suicide 1-800 service that everyone, everywhere in our country can access. Next slide, please. One of the cornerstones of our philosophy and what guides a lot of what we're doing as we're organizing our formal structure is a community-based community development model. We believe that having links in local communities to local agencies and existing services that help support individuals in crisis or those who are suicidal is important. We're not looking at another standalone system that's not linked to local resources. We believe that we will work to strengthen and improve the immediate condition of vulnerable individuals, and those who are part of our network are members of a continuum of care in their own communities. An interesting thing is that this model of service delivery is one we call a hybrid service model, because as many of you may know, those of you who are familiar with distress centers across the country know that often they use highly trained volunteers to offer service, but they also offer staff when necessary. Individuals that provide services are highly trained in suicide intervention and risk assessment and prevention. Next slide, please. So let's talk a little bit about the existing service strengths in our proposed Canadian Distress Line Network. And remember, I told you it was a work in progress. One of our great strengths is, of course, the call responders, who are highly trained to be empathic and non-judgmental in their interactions with callers. They, as we mentioned earlier, they provide a wide range of interactions, from emotional support to crisis de-escalation to interventions. Also, a very big part of the services they offer are referrals to local community resources or services. So not just a one number calls all, but ever close to someone who is calling in on the lines. These individuals who man the lines, the call takers, are experts in de-escalation. This isn't about saying, oh, just call 911 and we'll link you with the police or whatever. This is about de-escalating any situation and not having it go further. The intensity varies among all of the various calls that centers take, but the intent is always not to proceed to a crisis situation. Many of the centers who are part of the Canadian Distress Line Network initiative have both call-in and call-out services. Call-out services being when there are regular callers or individuals who use the service quite often. It's often a good approach to be able to call these individuals on a regular basis rather than just to wait for them to call in. And as we mentioned earlier, the services are obviously very strong and well established in the telephone environment, but also they're becoming chat-based, IM and texting in a variety of centers across the country. Next slide, please. So I guess you can get a sense from the words that I used earlier and the points that we were making that we're not looking at a big box store approach to service delivery. We are really looking at integration and developing the resources around the country in the communities they exist in. The majority of the centers and lines that are part of the burgeoning Canadian Distress Line Network provide 24/7 access in their regions. Not all. They certainly believe that a social support network or a safety net for vulnerable and risk individuals is very, very important. One of the very interesting things about our service is that we also provide very high quality data collection. This is anonymous. It's not attached to any particular individual. But what it is a record of the calls, and this then provides us with an opportunity to get a good picture of the psychosocial health of our callers. It's also important for us to remember that there are very well-established training regimes within all of the centers that allow us to have high-functioning responders who provide high-quality de-escalation support. And yet again, it's important to remember that many are linked and play a vital role in their local suicide prevention networks in their communities. Next slide, please. And of course, if there are strengths, there are gaps. So looking at some of our gaps, well, we certainly have to admit that the services of those centers that are part of our organization right now are primarily concentrated in and around larger urban centers and some smaller urban centers. We have come to know that the funding models are neither consistent nor necessarily sustainable in some jurisdictions, and you'll learn a little bit about those differences when we listen to the case studies presented by our other speakers. Also, although there's high-quality training, it varies, and the service delivery also varies across different provinces and territories in our country. Many centers, unfortunately, still have a heavy dependence on fundraising or grant applications as opposed to stable funding from their provincial health authorities. Technology is different, and it's not always linked, and that's certainly something that we're addressing as we go forward. And there's also struggles for 27 coverage across the different areas of the country. Next slide, please. Suicide prevention is a very important component of the service that we deliver. Call takers have specialized training in suicide prevention techniques, and those would be telephone-based. Many include assist or are based on the assist model. Centers also have established intervention protocols with EMS, 911, and their local police services. They're there to support and offer support to at-risk individuals, suicide survivors, concerned third parties, and also to service providers. The case studies will explore this in a little greater depth. Again, as I mentioned earlier, they often offer follow-up and call-out to at-risk individuals to wrap the service around them and keep them safe. However, as I mentioned earlier, these services are disjointed and they're not united. So one of our very key deliverables that we hope to give Canada is one easy-to-remember pan-national number that will help prevent suicide. For us, it's a very important next step. Next slide, please. What you have in front of you now is a schematic for demonstration purposes, just so that we can all get our head around exactly what a national 1-800 service model might look like. Initially, we're talking about this in a telephony environment, but the intent is to fairly quickly weave in chat and text services as well. So if you look at the left-hand side, you're going to get an incoming 800 call, and it's going to come into a central location which will have what we call geo-routing capabilities. That means that the system has the logic inside it to realize where the calls are coming from, what area, what province, and then to route it to the appropriate responding crisis line or center. So if you're in BC, you're going to be routed to BC services. If you're in Alberta, if you're in Manitoba, same thing. If you're in Quebec, you'll be routed to Quebec service. However, we know that there are often challenges with the volume of calls that are coming in. There may be a spike for some particular reason, and a particular jurisdiction or province might not be able to answer a call. So within this system, the intent is then to have a bouncing capability. This bouncing capability will allow the incoming call to be, the logic in the system knows that there isn't somebody, let's say, in Alberta who can answer that call. And if Alberta has then chosen BC to be its secondary, that call would be bounced to BC to be picked up. This system is intended to have 3 bounces. So that will hopefully provide us with an opportunity to have as high a call answer rate as 911 would have in your respective communities. So that's just a quick snapshot of what we're planning with regards to a 1-800 service. Next slide, please. So what we're going to do now is we're going to look at exactly what the service looks like. And it's my pleasure now to introduce Karen Letofsky, the Executive Director of Distress Centers Toronto, to do an urban case study. Karen?
Thank you, Liz. If I can have the first slide, please. I just wanted to give you a little bit of a background about distress centers in Toronto. According to our understanding, we are both the oldest and largest crisis helpline in the country, having taken our first call November 1st, 1967. And as Liz had mentioned, what's significant about that date is that in 1967, making a suicide attempt was still illegal. So we're talking about a movement, a helpline movement, which our center was at the forefront of, that was pretty pioneering in its time. Toronto, as most of or all of you know, is a city of 3+ million residents, especially if you take in the suburban areas. And it is one of the most linguistically diverse countries in the world. Cities in the world, Canada being up there as well. What's important about that is the challenges with respect to offering crisis support, certainly by telephone, when not everyone has language capacity to access those kinds of helplines. Our current agency is the result of an amalgamation of 4 independent and separate helplines that existed through the 80s and 90s and all came together around 2001. I think the unique view that we have of the helpline support we are able to offer is that truly we are offering multiple mental health services through one initial contact number. And those services, next slide please, those services run the gamut from social support to those who are isolated, to providing emotional distress management in real time, to crisis intervention, should the need be, in cases of suicide and even family violence. Our organizational model that we developed after the merger of all the organization includes a decentralized phone room system. We have 3 locations. As I will mention in a moment, 100% of our direct service is provided by carefully screened and trained and supervised volunteers. And we do know that volunteering is much like going to the gym. You're more likely to do it if it's close to where you live or work. Toronto, with respect to its own community development, also is built on a neighborhood model. So having a number of offices allows access through familiarity by being very neighborhood community friendly. At any given time, we have a responder staff of 400 to 600 volunteers, but at least 400 volunteers to maintain our shift coverage. And at our busiest, we have 9 lines, and during slower times, we reduce down to a minimum of 5 lines. Regularly, we receive in excess of 130,000 calls. And significantly, we are only able to respond to just under 80,000 of those. And capacity becomes a huge issue, which is why we were very interested in partnering in a Canadian Distress Line Network integrated system for those bounces that Liz was talking about. 80% of our calls are answered within best practice guidelines of 15 minutes. But I don't have to tell anybody, when you're in crisis, 15 minutes seems interminable. Our average time to answer a call hovers around 2 minutes and 20 seconds. Next slide, please.
And actually, if I can just ask you to move the mic back a little bit from your mouth. I'm hearing a bit of muffling near the end of some words. So that might be helpful with the noise.
Okay, thank you. Is this better?
Yeah, that's fine. Thank you.
So some of the things that might be good to know about a distress centers in a large urban setting is that 60% of our calls are received after hours when other mental health and social services are shut down. In fact, if you did a random call around to other programs and agencies after hours, most likely on their voicemail messaging, you would find a reference to the distress center suggesting that their callers call us. Support, as I had mentioned earlier, is offered in multiple ways. A significant number of our callers, in fact, are experiencing marginalization due to chronic mental health, physical health, and poverty issues. There are the other callers who really are dealing with an immediate high emotional intensity situation and are just looking for management in the moment. And we are also responding to those critical incidents that might require our intervention. If you could please, the next slide, thank you. It's also important to recognize who our callers are. 68% of them have identified a mental health concern. It may be diagnosed or pre-diagnosis. 13% of our callers talk about suicide in their contacts with us, and given the high volume of calls, that's a significant number of people who are sharing suicidal ideation or actually have escalated to the point where a threat is imminent. And just more than half of our callers, almost 60% of our callers, use our service on a regular basis to help manage their mental health status. It's interesting, and I think it's one of the things that's really not fully appreciated often about helpline models such as ours, which are totally volunteer delivered, is that in the history of our organization, almost 8,000 volunteers have been trained and have had the opportunity to gain experience in working on our helplines. That's a significant contribution to the community around capacity to support one another. And with this year's World Suicide Prevention Day theme, of connectedness, these are individuals who go on to careers in social service or mental health provision, and as well go on to become better parents, friends, and just associates in whatever environment they're working because of the training and experience, excuse me. But what is equally as significant is that given the volume of work and activity that we provide, only 30% of our budget is relatively guaranteed by funding through City of Toronto or United Way. We have the onerous task of having to raise more than $700,000 a year on our own. Next slide, please. Next slide, please. Thank you. Oh, sorry, we're back. If we could just go back, thanks. Our in-house services include a number of programs in addition to our distress line. What I do want to mention, because of diversity and inclusion issues in a city like Toronto, we do employ the 173 language interpreter service for crisis calls and have a TTY line for the hearing impaired. We also offer a survivor support program with face-to-face counseling in the aftermath of deaths by suicide or homicide. We have a caller reassurance program for seniors, and that involves regularly scheduled out calls to seniors who are registered in our program and have been referred because of chronic mental health concerns and isolation. Very active in community education and outreach, and very excited about our new online suicide e-resource library that has a librarian who is able to connect individuals who are searching for information with community-based resources. Next slide, please. In addition, with our mandate as a point of first access for individuals who are at risk, we have engaged and are currently working with some incredible partners around providing some dedicated services. Our EMS warm transfer line allows individuals needing emergency services in a suicidal crisis to be supported by us once the dispatcher has obtained all of the information, and we are able to stay on the line till they are on the scene to provide support. The PARO helpline is also innovative. PARO stands for Professional Association of Residents of Ontario, and we provide a crisis line for medical students and medical residents and their family who are experiencing emotional distress or might be in crisis. Crisis Link is an innovative program that partners us with Bell Canada and Toronto Transit Commission with a dedicated direct dial suicide hotline button on every single platform in the subway system. And St. Elizabeth's, nationally known for its mental health crisis support, we cover their crisis line from midnight till 8 o'clock in the morning. Next slide, please. With all of that, there are definitely challenges. Certainly, with being at full capacity, the two major issues are responding to surges in the aftermath of local, national, or international events. And after Robin Williams' well-publicized suicide, we saw a doubling in the volume of calls and a lengthening in wait times as a result of both the worried well, our regular callers, and new callers looking for support. It's also hard to prioritize calls on a general helpline with heavy volume and to be able to attend to crisis calls on a first need basis. Next slide, please. You know, as a framework for those challenges, I think we have to recognize that there is increasing need over time for the kinds of supports that we offer. So building capacity to be able to respond to that is a constant challenge. Our commitment to volunteerism, based on evidence-based research, which indicates that in a suicidal crisis, a trained layperson is as or more effective than a trained professional, we're really suffering from the change in the volunteer culture that every community is experienced with. We have a huge investment in training and preparing people to be in our phone rooms, but currently most volunteers are looking for short-term project-specific opportunities. So how do we develop a system of service that takes into account these shifts? Keeping up with technology and its impact on program delivery and ensuring that we have an appropriate infrastructure is always important. And a repeated theme, the lack of multi-year sustainable funding. Next slide, please. Having said all of that, we're excited about the opportunities that we see as we look to the future. We embrace some of the innovative service delivery models and the opportunities that they can possibly prevent for more effective service. The hybrid model that uses paid staff and volunteers to build capacity and to ensure that there is more helpline coverage is something we've been exploring. And as you can see from our partnership, the fee-for-service dedicated lines allow us to prioritize in a fully funded way. The new service delivery channels, technology, Liz has talked about crisis chat, text opportunities, but let's not forget face-to-face. Certainly with our immigrant populations in Toronto, there is some request for familiarity and face-to-face drop-in types of supports as well. Collaboration has been the key element in our growth during the past decade and as we look into the future. It's partnering with for-profit, as in our partnership with Bell and Toronto Transit, Professional and volunteer as our partnership with EMS and PARO. Multi-agency as our partnership with St. Elizabeth, and Distress Centers Ontario. Our networking organization enables us to find many partners across the province with a shared mission with whom we can work effectively. And we're hoping the same is true as we build our Canadian Distress Line network, where our potential partners can expand even further. And my last slide, please. The opportunities include looking at integrated helpline services, both of which have been named before, and as importantly, the development of best practice standards through knowledge exchange and building capacity in our communities through training and information sharing. Thank you very much.
Thank you very much, Karen. We really appreciate you telling us about all of the wonderful services and the community building and capacity building that your organization has been engaged in. You've clearly shown yourselves to be a forerunner in an urban model situation. So now it's my pleasure to introduce Janet Smith. She's the Program Manager for the Manitoba Farm and Rural Support Services, and she's going to walk us through a very different rural case study. Janet?
Thank you, Liz. I'm really happy to be here with everybody today on World Suicide Prevention Day and to tell you a little bit more about the Manitoba Farm and Rural Support Services. Our program began in the year 2000 as a response to an ongoing farm financial crisis in Manitoba, which resulted in very high stress levels amongst agricultural producers as well as the rural communities that they serve. Ours is a specialized service. It's the only one of its kind currently in Canada. It recognizes that the agricultural population has some very unique needs and cultural attributes. And when we look at the word agriculture, you can see it's kind of broken into two parts that focuses both on the industry as well as the people. And research has actually shown that farming is, in fact, one of the world's most dangerous and stressful occupations. People in rural and remote communities, including First Nations, are at higher risk of suicide due to access to lethal means, reduced access to mental health services, and lower help-seeking behaviors, among other issues. Within the Canadian context, a study that was done by the Canadian Ag Safety Association in 2005 looked at overall stress levels of Canadian farmers. And they found that, not surprisingly to those of us who work in this business, that 2/3 of Canadian farmers were feeling stressed on their farms, and the three main stressors being poor harvests and production, government policies, and farm finances. However, despite those high levels of stress, only 2 in 10 had spoken with a healthcare professional about stress and mental health. And the reasons for those lower help-seeking behaviors included pride and farmer independence. So the very things that keep farmers doing what they do is also, the double-edged sword to that is that they don't reach out for help easily. When they did reach out, they said that it was of the utmost importance that the person they were dealing with be knowledgeable about agriculture. So that's where we come in. Next slide, please. Our program is based in Brandon, Manitoba, which is about 2.5 hours west of Winnipeg. It's known as the Wheat City, or an agricultural hub, and it serves a very large rural and agricultural community. We know that 50% of Manitoba's population lives outside of the city of Winnipeg, and so our program serves both farmers, rural, and remote or northern Manitobans. We are fully funded by the provincial government through our Department of Health, and we are administered by Clinic Community Health Centre out of Winnipeg. Clinic, for those of you who don't know, is a very urban-based community health center that offers both primary health care, community education and training, and counseling services both in person and a variety of crisis lines. So our program, the Manitoba Farm and Rural Support Services, is the only off-site program other than a drop-in counseling office in Winnipeg, and we are part of counseling services. I think it's an excellent example of an urban-rural partnership. And initially, when we were started, there was a lot of concern that people in rural Manitoba would not want to be associated with clinic as it had sort of that urban reputation. However, I think we've really gone a long way on both sides to bridge that gap. It's important to note that all of our counseling staff, the paid staff that is, have farming backgrounds, and that's really important to our farm callers, as mentioned in the previous research. But we also have trained volunteers that work alongside us, and I'll talk about that a little bit more in a minute. Next slide, please. So our mandate, you can see a little farm scene here, is to provide information, support, counseling, and referrals to farmers, rural, and northern Manitobans. Next slide. A little bit about our actual services. We're open Monday to Friday, 10 a.m. to 9 p.m., including holidays, so we're not a 24/7 service. However, as was mentioned, I think by Karen, we do direct people who call after hours to other services within the clinic organization, and also offer people to leave a voicemail for a callback. In 2007, we began our volunteer training program, which enabled us to share 2 other crisis lines, that being the General Crisis Line and the Manitoba Suicide Line, which is a dedicated provincial suicide line with our staff in clinic. And it's a seamless service, so the callers don't know exactly who they're speaking with or where. They just know that they are having greater access to the crisis lines, given the fact that more people are staffing those lines. So in addition to the increased access, I think that one thing I could really speak to is the volunteer program enhanced our program morale and quality outcomes. So initially there was some, I guess, some hesitance because we had previously been a paid-only staff in our office, that the volunteers might not have what it takes to actually address the caller's needs, but very quickly we realized that that was not so. I think that they also bring more diversity. They reflect the overall changing nature of our community, and therefore can bring that to the calls themselves. And they become excellent ambassadors for this kind of work out in their own lives. Long and short, we couldn't offer the number and types of services that we do without our volunteers. In 2010, the Manitoba Farm and Rural Support Services began a pilot project of bringing online support to our clients, that being an email helpline and a chat service. Again, access to services is incredibly important, and in many rural areas, they just don't have access to face-to-face services. In addition, the pride and independence feature amongst a lot of rural and farmers is something that is attracting more and more people to our instant messaging program. We have a website and have social media presence through Facebook, Twitter, and YouTube channel, and we are always encouraging more people to visit those sites for information. We do, as best we can, outreach in public education, attending some of the large agricultural trade shows and health fairs in our province. And we also do a suicide bereavement support group that we host here in the office, which is in partnership with our local suicide prevention committee. And one thing I didn't have on this slide, but I would like to mention because it came up before, is that we do offer follow-up calls to individuals who are at medium to high risk of suicide, and call-outs if there is a third-party concern. So we are really, I think, within this industry, if we want to call it that, of providing crisis services, identifying what the needs in our community are, and to the best of our abilities, trying to fill those gaps. Next slide. So here's just a little view of our website. Next. And our email helpline service. Next. And our chat service. So some statistics. I'll give you all 3 lines that we are partnering with. The Manitoba Farm and Rural Support Services averages approximately 1,800 calls per year. The Clinic Crisis Line averages approximately 30,000 calls per year, and the Suicide Line is averaging in around 3,260 calls per year. And callers are calling for a variety of reasons: domestic violence, child welfare, addictions, mental health, housing, relationships, grief and loss, and suicide. And the farm-related issues are most often, as I mentioned before, related to farm financial distress and the related repercussions on the family. So next slide. So while we're very fortunate to have a stable core funding through our provincial government, that funding does not cover all of our adjunct services that contribute and enhance our core service of our telephone helpline. So as so many other organizations, we have need for more resources for outreach and public awareness. If people don't know about us, they won't know where to call, and so that requires a lot of ingenuity when funds do not provide us adequate access to public awareness. We also require funding for online emotional support, both for the software itself and to extend our hours of operation and to promote that service. So currently, Monday to Friday, 10 a.m. to 9 p.m., we know that most chatters want to speak to someone using instant messaging in the evenings and weekends, and that's currently not possible. We'd like to encourage more help-seeking behaviors among higher-risk populations that we serve: farmers, youth, First Nations, and I'd also add newcomer populations, as rural Manitoba is growing in terms of the number of newcomers that are coming to our province. It's really important, and part of the work that we all do, that we partner with other programs offering crisis support and suicide prevention. And I think that, again, it just speaks to the need for an organization or a network such as the Canadian Distress Line Network that can help us enhance that partnership. Thank you.
Thank you very much, Janet. That was a very informative presentation, and what it did help us do is to get a sense of the differences between two provinces, between two different settings. And that's one of the things that we honor in our Canadian Distress Line Network group, is we realize that there are differences. Our differences make us special, but they also provide us with an opportunity to learn from each other and learn from the experiences that happen in different jurisdictions. We are all about connecting Canada, and if Meg, you can move it to the next slide. I'd like to share with you 5 reasons why we think the Canadian Distress Line Network has a good idea. The first being that Canadians need access to an easy-to-remember single access point that's free and confidential in both a telephony environment, but also in an online environment. We think we've got a good idea because we are very interested in a routing setup, one that will direct calls to provincial crisis or distress lines or centers, allowing us all to support the very different regional and cultural needs of our different callers. Third, the service will also be answered by trained crisis and distress line workers, whether they be paid or whether they be highly trained volunteers. These individuals will all be specialists in suicide prevention and crisis intervention, what we call our hybrid model. Next slide. Also, the Canadian Distress Line Network is dedicated to supporting the various regional distress and crisis centers who currently work independently, and in some cases, because of funding or other resource constraints, have varying standards. We hope to have the opportunity to give them access to best practices, an accreditation process that will assure all that the services, the quality of service, the standard of training is the same across the country, and the great opportunity of knowledge exchange. And it's also hoped that the Canadian Distress Line Network will help newer and underfunded crisis lines reach their full potential. Next slide, please. So where do we go from here? We've obviously got some high hopes. We've got an absolutely rock-solid base to work on. We've got a lot of very motivated leaders and participants in the system. Where we go from here is to formalizing the structure of our national network, including those 3 key areas we spoke about earlier. and it means we're going to be developing those partnerships to help support the development of a national 1-800 service within the next 12 months. We need partnerships in a variety of areas, possibly other centers who haven't joined us yet or other lines. Certainly funding from not only government services, but also from public organizations and private organizations. And at the end of this, while you contemplate what we've shared with you today, we ask you, how will you help to support this initiative? Thank you very much.
Great. Thank you so much, Liz, Janet, and Karen. That was a wonderful presentation. Liz, I have to echo your sentiment earlier where we have so much to learn from both urban settings and rural and urban settings. And it's really exciting that despite the differences and challenges that you face, you've committed yourselves to establishing this 1-800 line, which is so important to so many individuals and communities across Canada. And I think that we can all agree that at the end of the day, we need this in place to help save lives in Canada. So we're now going to move to the question and answer component to this webinar. And so if you have questions, please enter them into the chat function. We have had a number of questions come in throughout the presentation, so we'll address those, and we'll get started right away. Thank you. Okay, so we are now into the live Q&A of the webinar, and we have received some questions, and the first one that I have is directed at Liz. Liz, and this came from earlier in the presentation. The question is, how does the network connect to schools in rural areas or on reserves? And I think the more important component of that question is on reserves.
With response to that particular question, the connection depends on the jurisdiction in which you're talking. Again, I can't stress enough that the relationships are very different across the various provinces. In some of the provinces, there are strong linkages with school systems and with individuals on reserves. Those are through the existing community organizations that are linked to those centers that provide telephony support. But we have to admit that in many areas, this is what we would consider a gap in an area that we're really working hard to address, and hope that this initiative that we're sharing with you today will address. Because as there's the ability to provide the telephony-based and web and chat services to everybody in the country, there'll be an even stronger push amongst the centers to link at a local level with those resources and make sure that when a call comes in as crisis is de-escalated, that the correct references and referrals are made to individuals either on reserve within the school system or generally within their own communities.
Hi,
Great.
It's Janet here. Can I also add to that?
Yes.
I also wanted just to say that I think that is actually one of the greatest strengths of the Canadian Distress Line Network model, in that given the case of the Manitoba Farm and Rural Support Services, for one, it's a specialized crisis line that reaches out to a population with unique needs. And I think that there's so much linguistic and cultural diversity throughout our country, and a lot of gaps in services currently. So the potential to route calls into specialized services is really something that I think is a strength of the network, and that being addressing the unique needs of callers, whether they be cultural or linguistic or other.
Great, thanks for that. The second question we have is for Karen, and the question was, when you referred to data collection on psychosocial health of callers, what questions do you ask callers?
A lot of our information emerges from the callers themselves as part of their narrative about who they are and what they're experiencing. So some of the information we would collect is whether they're living alone. It's the demographic information, whether they have some mental health concerns, what their current presenting problems are, what supports they have in place, what would be the most useful way in which we could respond to their specific needs at this point in time, and at the end of the call, whether there's been a change. So we really do look at outcomes as well.
Great, thanks so much. One question that we had is addressed to all panelists, so I'll let you decide who takes this question, but they were wondering at what point do you call the police when somebody is suicidal?
Liz, may I respond?
Please do.
I think that all of the member centres that are part of the Canadian Distress Line Network operate from a principle of management by assessment. And we have a very thorough assessment process based on standards that have been established around determining risk. And so the determination about when to intervene and send someone to hospital or bring in emergency services is based on, you know, exploring with the caller a variety of factors, and at the point that the risk is high or imminent, making that decision to get someone to hospital. And in large part, getting someone to hospital if they're not going to be admitted may make us feel better, but is not necessarily the best support of that caller. So we take that assessment process very seriously and really do try to match our supports and interventions with where that person is on the continuum of being at risk.
Great, thank you. Liz, this is a question for you, and it's from somebody in Ontario. They're wondering if you can provide some statistics on what the contents of a suicide-related call might involve.
Certainly. I'd like to do that. Here in Ontario, we have a very extensive, like I mentioned earlier, data system that allows us to consolidate all of the information from all of the 22 locations here in the province of Ontario and take a look and see what does that mean in an aggregate way. So if I can answer that question to the aggregate, when we have something that we would classify as a suicide call, it would have components such as assessment, as Karen spoke to. So moderate to high risk assessment might be 8% of that call volume. 37% of the callers on a call that we would identify as having a suicidal component would be experiencing ideation. 2% would be interventions initiated, so that would be police or 911, referencing the previous question. In 1% of our calls, they are actually an attempt in progress. 11% of our call volume of suicidal calls are speaking with survivors of suicide. So a very, very important component of the care and support that we give to individuals. 39% of the individuals who discuss suicide with us have actually engaged in prior suicidal behavior.
And then we have time for one more question, and this one is for both Karen and Janet. And the question is, why does the Toronto case study show that they have to fundraise 70% of their operating dollars, and in Manitoba, they're fully funded?
Maybe you'd like to go first, Janet, since you're in the fortunate situation.
Okay. You know, I can't speak to the politics behind it, although I can say that it was a recognition that callers in crisis, in particular to suicide crisis, the desire by the provincial government was that none of those calls would go unanswered. And so there was a decision to dedicate core funding to a 24/7 dedicated suicide line. And that happened back in 2006, 2007, and was administered by Clinic Community Health Center, which has been a long-term partner with the government and has a good reputation in providing high-quality services. So that was what happened here in our province.
And in Ontario, to the contrary, I don't think there's been a very well-defined suicide prevention strategy, and certainly not adequate or even significant dollars dedicated towards it. And part of the problem is we damned ourselves by our own success, since so many of the helplines in Ontario were grassroots organizations that learned to do a lot with very little, and determined very early that they had to be self-sufficient, that to some extent were taken for granted. Certainly when I think about North America in the year 2014, I think no one expects that a large urban center would not have a dedicated helpline, crisis line, and yet nobody wonders where the funding for that comes from, and I think there is an assumption that it is government funded, and so there's been this huge gap.
Great. Well, thank you so much again for your presentation today. As we mentioned previously, the slides and full recording will be available on the archived website within the coming week, and there will also be French slides available for our French-speaking participants. I would just like to remind everybody again about the virtual conference approaching this November, from November 19 to 21. The theme is Connecting Canada, Conversations about Communities, Collaboration, and Hope. A full agenda will be available by the end of September, so please check out castconference.ca for more information about that. And if you'd like to register, you can also visit the website and find information there. So thank you for everybody for participating today, and I hope that everybody had an enjoyable World Suicide Prevention Day. We look forward to hosting you at our next regularly scheduled webinar taking place in October on the second Tuesday at 1 p.m. Thank you, and have a great day.